Welcome back to your next tape, and we're here for macrocytic anemias, which is predominantly B12 and folate deficiency, as well as hemolysis. Once again, we commit ourselves to the inexorable and relentless quest to polish our own art. We have a 78-year-old man who's coming to the office because he's numb and tingly. He's tingling and numbness of his hands and feet. Tingling and numbness of his hands and his feet. And the guy is got a little memory problem. He is a big-time whopping alcoholic 78-year-old man. And he is drinking all the time, and his memory sucks and he's tingling. It's a bad combination. Must have anemia. After all, we are in the hematology section. He's got a hematocrit of 30 and an MCV of 110. Now, what would you do first in the evaluation of this patient? What's the best initial step? What's the most appropriate action at this time? What you want to do now? ¿Qué tú quieres ahora? And the answer is to say a smear. And the reason that you're going to say a smear is because the difference between B12 and folate deficiency and patients who have alcohol-induced disease is that patients with B12 and folate deficiency have hypersegmented neutrophils. And that's the difference. These people are hypersegmented. Whereas, if this was just a normal neutrophil, the likely diagnosis in this patient would be alcohol-induced anemia, alcohol-induced neuropathy. Remember, alcohol can do everything that B12 and folate can do. Alcohol can do everything B12 can do, including the neurological problems. But alcohol does not make you hypersegmented. Alcohol can cause peripheral neuropathy. Alcohol can cause dementia. Alcohol can cause myopathy. But alcohol does not cause hypersegmented neutrophils, and that is the difference. Hypersegmented neutrophils is B12, folate, and a few antimetabolites such as 6-mercaptopurine. With the exception of that, all the other causes of macrocytic anemia, liver disease, hyperlipidemia, all of them just cause big fat cells. Hypersegmented neutrophils is first. The clinical manifestations of B12 can be any form of neurological problem. Now, you could have dementia, you could have peripheral neuropathy, autonomic neuropathy, sensory neuropathy. You can have anything. So what can you get? Anything. What's the most common? Peripheral. However, you can get anything. You can get dementia. You can get autonomic. You can get anything. It's just that peripheral neuropathy is the most common thing. The most common thing is the peripheral, which is the numbness and tingling of the hands and feet. You can get anything from dementia to personality disorders, psychosis to loneliness to an intense craving for coffee, all out of B12 deficiency. But it's just easier to say anything, and peripheral neuropathy is the most common thing. That's the same as alcohol, by the way. Hey, is it reversible if you treat that B12? And the answer is yes. The shorter the duration of symptoms, the greater the degree of reversibility. The shorter the duration of symptoms, the greater degree of reversibility. That means if you have this for a few weeks, it'll reverse. Now, if you have long-term dementia and you got a guy walking around on his hands and knees barking like a dog for weeks, or months, that's not going to reverse itself. If you got somebody who's got long-term memory problems, little old ladies in nursing homes, kyphotic, shrunken up, and demented for years, you don't give them a B12 shot and have them jump out of bed and say, "Hi, I'd like to go to Starbucks too." So peripheral is short-term, peripheral reverses, but long-term does not. And the big difference is folate has no neurological problems. So this person could have had B12 and folate, alcohol B12 and folate, but they couldn't have had folate alone because there's no neurological problems. They couldn't have had alcohol alone because there's no hypersegmented neutrophils. Remember, an average number of lobes greater than 4 on average is hypersegmented. Greater than 5% at 5 lobes, or even 1 6-lobe neutrophil, and we have megaloblastic anemia. Now, B12 deficiency and folate deficiency are diagnosed by B12 and folate levels. Oh no, this is getting too easy. It can't be that easy. Your folate deficiency, you have a low level? Doc, it hurts when I do that. Have some folate? No. Tell me I didn't spend all this time in medical school to say get a level of folate and replace the folate. No. Yes, it's true. That's all there is. B12 is more complex. B12 is more complex. Folate, you should see in the history, you don't have to, but you often see some form of decreased dietary intake. I'm an alcoholic who doesn't eat green leafy vegetables. I don't have salad ever. I have 100% meat. I never have any green leafy vegetables. I don't take vitamins. I get increased meat and fat, but I don't get anything that has the folate on it, and I don't take vitamins. Or some form of increased cell loss like psoriasis or skin lesions where you're desquamating, or something like sickle cell. In the absence of increased cell turnover like sickle cell, in the absence of increased cell turnover from sickle cell or psoriasis or pregnancy, it's always from decreased intake. The only way to use up your folate is you've got to be making genetic structure more often than you usually do. People with sickle cell disease have reticulocyte counts of 15, 20, 25% routinely. People with chronic blood loss, but it's usually not that much. A chronic compensated hemolysis. You're having reticulocyte counts of 15, 20% all the time. They got to make that genetic material, and we use up all the folate. Psoriasis, I'm scrapey, I'm flaky, I'm scraping and I'm flaking. Or pregnancy, where you've got to make new cells called mi bambino. In the absence of increased cell production, you always have to have a decreased intake. Now, that doesn't happen in B12 deficiency because in B12 deficiency, you have so much storage, it's very hard to get from decreased intake. Now, if your level of B12 is low and you have this presentation, you're done. Replace the B12. Well, then what do I need a increased methylmalonic acid level? What do I need an increased methylmalonic acid level for? Because sometimes people are deficient in B12, but they have a normal B12 level. Sometimes people are deficient in B12, but they have a normal B12 level. How can that be? Because transcobalamin, the transporter protein for B12, is an acute phase reactant. Somebody steps on my toe, I get an infection, I get stress, I get trauma, I get cancer, my transcobalamin level can go up. And it can make the B12 level artificially normal. Even though you are deficient, it can become artificially normal, even with deficiency. And that's why you have a B12 level and a methylmalonic acid level, because this will be elevated even with a normal B12 level. So B12 deficiency. When do I get methylmalonic acid? When I got a story like B12 deficiency, but a normal B12 level, methylmalonic acid level, and replace the B12. Now, Schilling's test is one of the least useful tests because Schilling's test has largely been replaced by antibodies against intrinsic factor and parietal cells. In other words, I don't need to do a long, cumbersome, complex Schilling's test when I can simply measure the levels in the bloodstream of antibodies against intrinsic factor and antibodies against parietal cells. In other words, pernicious anemia is essentially an allergy against your own intrinsic factor and parietal cells. I've developed an autoimmune phenomenon where I'm attacking my own stomach. How did that happen? The way it happened is I've developed this autoimmune phenomena, and this is just the finding of having antibodies against intrinsic factor and parietal cells, so no wonder I have pernicious anemia. So if they give you a choice and say which of the following is the most specific diagnostic test for pernicious anemia, you're going to say anti-intrinsic factor and anti-parietal cell antibodies. And that replaces the Schilling's test. Schilling's test would be to isolate the rare cause of pernicious anemia that's not due to this autoimmune phenomena, that is due to Diphyllobothrium latum, or is due to another form of deficiency, such as pancreatic insufficiency or bacterial overgrowth. Each of those is less than 1% of causes. Most is simple old pernicious anemia. I have macrocytic anemia with hypersegmented neutrophils. You could have B12 deficiency with just the neurological problem, just the hematological problem, or both. You don't have to have one to have the other. You could have each of them individually. You don't have to have one to have the other. Folate deficiency, hey doc, I'm deficient in folate. Have some folate, why don't you? Schilling's test is only in the rare person in whom you know that there's B12 deficiency and you can't figure it out. The person in whom you have B12 deficiency and you're not sure if it's pernicious anemia because the intrinsic factor and parietal cell antibodies are negative. Schilling's test is not to diagnose B12 deficiency. Schilling's test is to determine the etiology. Thank you very much. Should we go on to hemolysis now? Are you ready for something new? Are you? We don't have to. We could stop right here. Did we take just a second to feel good about ourselves for a second? Oh. You know, it's very important to feel good about accomplishments just for a second. Yes. Do you know what I would do if I won $2 million in the lottery tomorrow? Do you know what I'd be doing? Let me think. If I won $2 million in the lottery and I never had to work again, you know what I'd do? I would be here right now with making videotapes through Kaplan, sending out this message to you, and that's what I'd be doing. I'd be doing exactly what I'm doing now. So if you didn't have to work for a living, if you could do anything you wanted just for the sake of interest and because it makes you happy, what would you be doing? I would like to think that you'd still be out there in video land. That's the way I feel. I hope you feel that way too. That's how you know it's the right decision.